So to start with, we have the presidential oration of 2021. So we were discussing yesterday how Sanjay Kalra had to spend his tenure of presidency almost in an entirely virtual mode. And then Dr. Ganapathi sir took over, and he took over the medallion yesterday, and he's going to hand it over again today. It's not something that we would have wanted to have happened, but unfortunately that did happen. But I think it's been a wonderful experience to work under both Dr. Kalra as well as Dr. Ganapathi. And it's my privilege and pleasure to invite Dr. Ganapathi onto the stage for the Presidential Oration 2021. And it's customary to introduce the speaker, but I don't think, sir, particularly in your backyard, you need any introduction. So I'll hand over to sir and ask Madam Dr. Kotwal and Dr. Murthy to introduce and then hand over the medallion.
Very, very good morning to everybody for day 2. And we're looking forward to a lot of excellent presentations today as well. I think yesterday was a very, very grand show. Welcome, Dr. Ganapathi. Congratulations for this presidential oration. And he is professor and head of endocrinology at St. John's Medical College, Bengaluru. And he's, of course, giving a presidential oration as the president of the Endocrine Society of India. He's been secretary of the Endocrine Society of India from 2006 to 2009. I think that was the time when I took over as president. So I think he was the first one to announce my result, possibly, that had won. He's also been the vice president in the past, 2013-14. And he's a member, of course, of the society, RSSDI, and the Endocrine Society of America as well. He has received the RSSDI Oration Award 2014 and the Nada Gowda Oration Award 2009, Sunil Kumar Basu Oration Award 2019. He has over 85 publications in peer-reviewed journals with special interest in GDM and hyperparathyroidism. So we will give you your shawl and your memento.
Thank you, Dr. Sujay. Thank you, chairpersons. It's my proud privilege to deliver this presidential oration in front of my own crowd, you can say, the Bengaluru crowd, and in the state of Karnataka. And more importantly, it's the 50th year of the Endocrine Society of India conference, so that's the other uniqueness of this. Yesterday, Dr. Sanjay Kalra gave presidential oration on we should do more research, and if you look into if you go into the Google and look into who are the top endocrine fraternity who are doing research, it is actually the basic scientists are the ones who are doing it. I acknowledge that, and with that background, let me begin with I would like to extend my gratitude to Professor Ajay Dash, who's no more, passed away in August this year. He has been my mentor, my guide, philosopher, everything. What I am today is because of Professor Das. My journey, hyperparathyroidism, what I have learned. Began seeing cases of hypercalcemia driven by hyperparathyroidism in clinical practice. If you go into the literature, more than 90% of hypercalcemia are secondary to malignancy or hyperparathyroidism. But the incidence of hyperpara has increased significantly in the last 2 decades, probably because of the availability of multi-channel biochemistry autoanalyzer. So we decided to look at our data on hyperpara. We published one series of a 5-year retrospective study on primary hyperpara in South India, the emerging role of minimally invasive parathyroidectomy and pre-op localization. We looked into the clinical features and characteristics of patients with hyperparathyroidism, biochemical parameters, correlation between clinical and biochemical parameters, and the pre-op localization methods and utility or accuracy of each of them. What we found was more than 60% of the cases were still symptomatic. So in the Western world, it's almost come to 90% are asymptomatic and only 10% are symptomatic. And if you see the clinical features of patients with hyperpara, 25% had GI symptoms, around 37% had musculoskeletal symptoms, 25% had renal manifestation, 9% had CNS manifestation. In fact, one of them presented with hypercalcemic encephalopathy, who had a calcium of around 17, who recovered after hyperparathyroidectomy. Coming to the biochemical parameters of patients with primary hyperpara, the serum calcium, the mean was around 12.7 milligrams per deciliter. The phosphate was around 2.3. The parathyroid hormone levels were quite high, 602. The 25-hydroxy vitamin D levels were low in the majority of them. Alphos was moderately elevated, 375.5. 24-hour urinary calcium was also high at 332 milligrams per 24 hours. So we did find a relationship between vitamin D and PTH pre-op. So when you had lower vitamin D, the levels of PTH were higher. And we did also find a relationship between vitamin D levels and calcium, with the lower vitamin D level having a higher calcium levels. So the salient findings in our study was close to 40% were asymptomatic, similar to what is reported elsewhere from the country now. The mean age was around 48 years. It's much lesser than developed countries, which is around 55 to 62, probably related to vitamin D deficiency. All had hypercalcemia, hyperphosphatemia, and approximately 60% had elevated alkaline phosphatase. Maybe 100 would have had it had we done a bone-specific alkaline phosphatase. Then there are some unpublished data, asymptomatic versus symptomatic. So we had 33 asymptomatic cases, and they were picked up during, in 9 out of them, they were picked during routine health checkup. Evaluation of unrelated disease, peri-op evaluation around 21%. Somebody had a gallstone disease, was for surgery, and we found that. One patient had a depressive disorder, and we find that the patient had hypercalcemia. Totally we had around, if you compare them, symptomatic versus asymptomatic, though if you see age, not much difference, sex, everything were almost matched between symptomatic and non-symptomatic. But then we did find that the PTH levels baseline were quite high in the symptomatic, which was around 1,212.5 picograms per ml, versus in the asymptomatic, which was lesser, though it did not reach statistical significance. Maybe the numbers were less, probably a little bit more number will tell us that. So otherwise, you take vitamin D, 24-hour urinary calcium, duration of surgery, gland weight, also there was not much differences. When we compared our study with Dr. Mittal's study, the age at diagnosis was older in their group was ours. There was not much difference, symptomatic versus asymptomatic. The female to male ratio was 1.9:1. In the Mittal study, it was 1.42:1. The percentage of asymptomatic patients were 38%, it's around 41. Adenoma gland weight was lower in asymptomatic. Here it was approximately 50% of that of classical HPT patients. And the PTH levels were lower in asymptomatic. Here also approximately 50% of that of classical hyperpara patients. We did find a significant positive correlation with PTH more than 600 and the gland weight. Once you cross 600, we found that the weight of the gland increased. And if you see the relationship between parathyroid hormone, calcium, parathyroid gland weight, and 24-hour urinary calcium, we did find a relationship when the levels were, you can say, more than 600. We did find that the calcium levels were quite high, 13.69, compared to those who had less than 600, where the levels were around 11.93. Gland weight also, when the levels were more than 600, it was around 9 grams, compared to that when it was less than 600, which was around 2.42. And the 24-hour urinary calcium, not much changes, you can see it was almost similar. Now coming to the utility of pre-op localization, why do we want to do it? To facilitate minimally invasive parathyroid surgery. You could identify ectopic location of parathyroid adenomas, and the common sites which we found was retroesophageal space, lateral neck, and in the mediastinum. And the pre-op localization modalities which we did was ultrasound. As you know, it's the cheapest. Technetium system maybe in the majority of them we did. CT MRI, less utilized. We did do C11 methionine PET CT. It was helpful in special situation for localization. And then we also did 4D CT in one patient where it did help us in localization. So in our study, the choice of imaging was based on affordability and clinical scenario. All patients underwent ultrasound neck, and the affordable patients underwent additional imaging starting with technetium-99 system AB scan. So if you take our data, we had 54 patients who underwent ultrasound. System AB scan was undertaken in 36 patients. It was positive in 26, 10 were negative. And in the 10, 8 underwent C11 methionine PET scan. It did show positivity in around 6 patients, 2 were negative with the PET methionine. So among the patients who underwent C11 methionine PET CT, 2 patients probable they had, did show some probable parathyroid adenoma in ultrasound, but it did not show any uptake in the technetium system AB scan. The remaining 6 patients were negative on both ultrasound and system AB. In 6, we did have successful localization, and the remaining 2, where it was negative, they underwent the characteristics, the exploratory parathyroidectomy. The surgeon's hand is supposedly the best for localizing these type of patients. Coming to the imaging characteristics of the parathyroid adenoma, so ultrasound, it did show a positivity of around 72 and a false negative around 27%. System AB was almost similar to that of actually an ultrasound. PET methionine in those who are negative, so in them we did show a positivity of around 71% and a false negative of around 28.6%. Now coming to localization, surgery is the only curative treatment for patients with hyperpara. 4-gland exploration was long considered as the gold standard surgical approach, and it still remains the procedure of choice in patients with no suggestive lesion on localization studies. So with the availability of various imaging techniques nowadays, it's possible to subject the patient to minimally invasive parathyroidectomy, and the other modality is the 4D CT. So here it's similar to the dynamic contrast MRI of the pituitary. We take sample images after contrast to assess the washout. So we did this in one patient. We found a well-defined enhancing lesion, 9 × 5 millimeters, was noted in the left paratracheal region in the suprasternal notch, anteromedial to the left common carotid artery. The lesion shows intense enhancement in the immediate post-contrast phase, with the rapid washout of the contrast in the early and delayed phase. So you can see here, so there was an intense uptake, rapid washout in the early and the delayed phase. And the characteristics of the vessels, the lymph node and the thyroid is different. So this is how you actually differentiate it. So with the CT, 4D CT, we could localize the parathyroid. So the diagnosis of hyperpara is actually biochemical. You have a high calcium, a low phosphate, high PTH, the diagnosis is confirmed. Localization, either radiological, if there is a facility for that, or surgical exploration. And treatment surgery is usually curative. Now, how do you ensure surgical success cost effectively? So the most common strategy employed worldwide is intra-op PTH monitoring. There's a criteria known as the Miami criteria. It requires 4 intra-op PTH samples. One, they take pre-skin incision before that. Then the pre-gland excision, they take another sample. 5-minute post-gland excision, 10-minute post-gland excision. And more than a 50% drop in the intra-op PTH decrease between the pre-resection and post-resection values suggests that probably we have removed the gland completely. So these assays are used at various intervals before and after gland excision. It requires multiple blood samplings and dedicated machines for analysis, and this adds to the overall cost and complexity of the procedure. So we, in our hospital, we did a modified intra-op PTH assay utilizing a single sample intra-op PTH taken 10 minutes after excision. We should do all the patients at least a week prior the PTH level before the surgery. So we took that as the baseline, and one single sample was taken 10 minutes after that. So we published this in a paper. So simplified intra-op parathyroid hormone assay for primary hyperpara in a resource-limited setting. So you can see the pre-op levels were around 1,000, and 10 minutes post-op it had dropped down to 174. The first day post-op was 23. So you can see a 70% fall. It showed a 83.9%, 80% fall 69.4, and a 90% fall in 23.6. So the conclusion from this study was, traditionally, the intra-op assays are used at varying intervals before and after gland excision and require multiple blood samplings, which add to the overall cost and complexity of the procedure. In this study, we utilized a single sample intra-op PTH taken 10 minutes after the excision. The sensitivity of the assay in a single gland disease was 97.8 for a 50% fall, 95 for a 60% fall, 84% for a 70% fall. So using the pre-op diagnostic value as baseline and a post-excision single-shot intra-op PTH assay, a 50% fall offers a sensitivity of 98% in a single gland benign disease. So because of this single sample, the cost of this actually came down by at least 1/4, and leading to as much as a 15% reduction in the total surgery cost. This is in our hospital. So the result presents here demonstrate a drop by 50% from baseline PTH, even if measured from a single peripheral venipuncture, accurately predicts operative cure. This is not really about hyperpara, but then post-thyroidectomy hypocalcemia, can we identify those at risk for post-op hypocalcemia? So the ability to predict post-op hypocalcemia can ensure safe and early discharge. Prompt replacement therapy is required to avoid discomfort. So we found that rather than a single value, so the American Thyroid Association says the IPTH less than 15 or some take 10 is a criteria that when it is less than that, the risk of the patient developing post-op hypocalcemia is higher, and in them we'll have to supplement them with calcium and vitamin D. So we found that the decline, not a single value, in the PTH level was a better predictor than PTH values alone. So the parathyroid decline levels are better markers of symptomatic hypocalcemia following total thyroidectomy than an isolated PTH number alone. So we looked into asymptomatic patients around 76 and symptomatic hypercalcemia were 19. In around 18 patients, parathyroid, because it was a total thyroidectomy, this surgery was done for both benign and malignant thyroid disorders. And in around 18, inadvertent parathyroid removal was done, but then they were auto-transplanted later. So here what we found was the PTH level 4 hours later, and we also looked into the PTH level first day post-op. So one is you take IPTH levels. The other one is the decline, absolute decline, 4 hours, and the next day, post-op day, morning when you do that sample. So that number, the difference between that is the delta PTH or absolute PTH. And then you have what is a relative PTH percentage. So that is the same as this. Post-op 4 hours PTH level minus on day 1 PTH divided by PTH at 4 hours into 100, the percentage. So that's a relative PTH decline. So what we found that in the ROC curve, the absolute IPTH decline, which is 4 hours minus the day 1, and the relative IPTH decline, which I told you the formula, they did have a higher area under the curve than the isolated single number of, say, less than 10 or less than 15 alone. So the summary from this study was hypercalcemia is a frequent complication following thyroidectomy which can delay discharge and increase overall treatment expenditure. Patients underwent either total thyroidectomy with central neck dissection or central neck dissection plus modified radical neck dissection, depending on the type of the patient category. So some did have malignant disease and some had benign. Intact PTH, absolute IPTH decline, relative IPTH decline were calculated and correlated with symptomatic hypocalcemia. The comparisons between groups were measured by chi-square test, Figures exact test, and Mann-Whitney test. A total of 32.6% of patients had biochemical hypocalcemia, 20% had symptomatic hypocalcemia. So the mean calcium on post-op day 1 was 8.3 and on day 3 was 8.4. So the median PTH measured 4 hours after surgery was 24, on day 1 was 28. So the absolute IPTH decline and the relative PTH decline was significantly higher in patients with symptomatic hypocalcemia. So in this study, we took a total of 20% fall in PTH level, that is a relative PTH decline. It can be a useful marker of hypocalcemia following thyroid surgery and has the potential to facilitate a safe early discharge for patients undergoing total thyroidectomy. So my journey with hyperpara started with describing the spectrum of hyperpara in our population, utility of cost-effective measures like ultrasound for pre-op localization sensitivity was almost similar to that of System AB. Advanced modalities in subset of affordable patients like C11 methionine, PET-CT or 4D-CT, cost-effective identification of surgical success, and prediction of post-op hypercalcemia. So we require to actually do more in this bone and mineral metabolism area, and we have the ISBMO, they're doing a great job. We have these luminaries who are there. The president, next president-elect is also one of them, and we have reached now in such a way that his photo now figures in Williams' textbook of endocrinology, and we are proud of our president-elect, Dr. Sanjay Badada. So the future is bright, and we require to do more and more. So and in fact, they also come out with a position statement for the diagnosis and treatment of osteoporosis in adults. So I would like to end my talk with the saying, research is to see what everybody else has seen and to think what nobody else has thought. So this was by Albert Zent Gorgi. Thank you for patient hearing.